Medical transplants include heart valves from pigs to bone marrow from a live donor or the vital organs from a victim of a tragic accident, replacing parts of the human body. The doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
What if there was a way to heal someone? To have the power to stop someone from dying? There is a way. And it's you. Thousands of patients are searching for a marrow donor. Join the BeTheMatch Marrow Registry and be the one to save a life.
Hello, and welcome to On Call Television. Life-saving organ transplant is one of the great advances in modern medicine, but unfortunately, the need for donations is much greater than the availability of organs and bone marrow. People who need an organ transplant often have to wait a long time for one. Sadly, many people die before a suitable donor is found. Other transplant issues have to do with the complexity of the procedures, the story of harvesting cadaver kidneys, hearts, and other parts, the controversy of stem cells, balanced with the glorious recovery of people who would certainly die without such a rescue. Here to discuss such diverse and important issues are two experts. Dr. Christopher Auvenshine, who attended medical school at the University of North Texas Health Sciences Center, Lubbock, Texas, and his residency in general surgery at the University of North Texas Health Sciences Center, Fort Worth, and his fellowship in liver transplant at the David Geffen School of Medicine at UCLA. Dr. Auvenshine practices at the Avera Medical Group Transplant and Liver Surgery Center. And Dr. Mumtaz Niazi, I said that right, Mumtaz, correct, who attended medical school at Punjab Medical College in Pakistan, internal medicine at Long Island College Hospital in Brooklyn, and his fellowship in hepatology at New Jersey Medical School, Division of Hepatology, Newark, New Jersey. Dr. Niazi practices at Avera Medical Group Liver Disease. Are you or a loved one waiting for a possible donor match? Has a family member been a donor for someone else? Do you have questions about the future or the policies of transplants in America? Tonight, we would appreciate your questions about anything involving transplants. Call 1-888-376-6225, or you may email them to questions@oncalltelevision.com. Thank you, gentlemen, both for joining us.
Thank you for having us.
Mumtaz, talk to us about your experience. You started in Pakistan, I mean, that's your home country.
Correct.
And then you moved here when?
I came here in 1998, and then as a pharmaceutical graduates, we have to take the exams to be in United States, and they call them USMLEs.
Yes.
So I did that, and then I started residency in New York, Long Island College Hospital, and graduated in 2005, July, and then I did fellowship in hepatology in New Jersey, and after that I joined a liver transplant program in Philadelphia, Albert Einstein Medical Center, where I worked for 3 years as a transplant physician, and then subsequently joined Avera almost in mid 2010.
So you're a transplant hepatology internal medicine doctor.
Correct.
Great. And Chris, you're a surgeon.
Yes.
You're a Texan boy.
Yes.
You grew up in Texas.
Grew up in Texas, yes, Houston.
And so you've been here how long?
I've been here since 2009, so about three and a half years now.
And tell me a little bit about what brought you into doing surgery.
I actually did not like being in the clinic. I loved being in the hospital, and then I love working with my hands, and so when I did my surgical rotation, it was a perfect fit.
And then from that point, you decided transplant surgery because? I
did. There's a number of reasons. Transplant patients are in my opinion, are the very sickest patients in the hospital. It's still an opportunity to do a large open case. It's very difficult to do a minimally invasive transplant surgery. And the science behind transplant is complex and very interesting.
It is, isn't it?
I believe so.
It truly is. Preparing for this, and of course we've done a number of transplant shows. It's just amazing. It blows me away, the history and all of the lessons, the layer upon layer of science that we've had to do to get to where we're at and to the success that we have. Well, Avera, you both work for Avera, yes. And this year we've just reached, what, 1,000? Tell me about that. You guys must be excited about this. The 1,000th transplant case, right?
Yes, so you combine the solid organ and the bone marrow transplant programs, and together we've done now over 1,000 transplants.
So I think that's something to be proud. That started how many years ago?
I believe our start date was 1996 or 1997, so we've been functioning now well over 15 years.
So we do bone marrow transplants, stem cell transplants, and we do kidney transplants,
yes.
And kidney pancreas transplants.
We'll do kidney and pancreas. We'll do them together, and sometimes we'll do pancreas alone or pancreas after kidney transplant.
Right.
And we have a collaboration for liver transplant. I mean, eventually we'll hope that we'll start a transplant here in Sioux Falls. That collaboration is very unique, that we do pre-op care and post-op care here in Sioux Falls. But the actual liver surgery is performed in Milwaukee. So liver transplant surgery is a very complicated and long process. So to prepare the patient to go for liver surgery, we need a cirrhotic patient who is already into a phase that if they don't get transplanted soon, they die. So they are very high risk to be death to begin with.
Right.
So they need to be evaluated really carefully. That includes cardiac evaluation,
yep.
Pulmonary,
kidney.
Liver. Exactly. So
get into kidney trouble.
Yep. So they need to be evaluated first. They need to be prepared. They need to have all the medical clearance, including psychosocial evaluation, who will be responsible for taking care of the patient post-op, pre-op, and all those things. And keeping them alive is a big problem because they die. So you have to keep them alive. So that process we do very well so far, and we're hoping that in future, in a couple of years down, so
we'll be doing the liver transplant itself.
Correct.
But I mean,
we have a whole team dedicated for transplant, which is needed for liver. This is only missing piece is the South Dakota state has to approve us.
Yeah. Oh, so you're ready. It's the approval thing.
That's true.
That's very interesting. Well, I know I have a dear friend who had a liver transplant. It was a living donor transplant from his wife's cousin. And he's alive and well, and he was so very sick prior to his transplant. And of course, you don't get the transplant till you're sick enough, but then you get too sick so that you can't make it through the surgery.
That's true.
There's the dilemma.
That transformation's amazing.
I wanted to talk about the issue. There's a lot of issues. One of them is bone marrow transplant. We need to talk about bone marrow transplant because we do that here. Do either one of you like to talk about bone marrow transplant issues?
I would forego that. I'm solid organ transplant only, and as a surgeon, my scope is even more specialized in that regard.
Right. Do you have?
I mean, we have a little bit of collaboration in that case because a lot of bone marrow transplant patients, they have run into liver issues. So we do see them periodically with the bone marrow transplant team itself on liver issues if they have liver abnormalities, and they get graft versus host disease in which liver get hit, and those patients we do see time to time. But specifically commenting and what are the criteria, how they do it, and what are the leading causes and all those. Unfortunately, we don't have our third expert with us, so that
Well,
will
we'll
be
have
nice.
him again.
Yeah, absolutely.
But let's talk about graft versus host. That's such an interesting thing. So graft, meaning the kidney that you transferred, versus host. So the kidney says, hey, this is a foreign substance I'm living in, and rejects the body. Now the other part is host versus graft, where you put in a kidney into somebody and the host says this is a foreign substance, it's a sliver, or it's an infection, it's a parasite, get away, kill it, destroy it, protect your body. And so that's called the graft and host diseases.
And the other
Explain
one,
that a little bit.
rejection.
Yeah.
The first component, which is like when the body rejects that organ, that's we call it rejection.
Rejection.
And for that, we give them immune suppression medication from get-go.
Right.
And then we keep them lifelong. And this is what post-op care is about, because those patients has to take these medication, and they have their own side effects.
Right.
One of them is renal failure, diabetes,
Kidney
high blood
failure,
pressure.
diabetes,
Exactly.
yeah.
So we have to titrate their medication very carefully. And Dr. Auvenshine and our Dr. Tariq Khan, they're pretty good in doing that.
Yes.
And the other one, the graft versus host disease, that's most common actually in the bone marrow compared to the solid organs.
So you transplant a bone marrow. I mean, you give them a new bone marrow.
Correct.
And then the bone marrow that you've given them decides that the body is foreign and rejects the body. That's graft versus host.
Correct.
So yeah, and that happens. You don't use the same medicines.
Yes, we do almost the same item, but the concept here is a little different. And it's still controversial and very debatable condition, in which some advocate that probably we need to give more rejection medication, and it's a component of rejection. And other favors, well, it's not rejection, it's your body is making those antibodies which are attacking your own organs. That includes lungs and lining of the gut and the liver and all the mucosal area and the kidneys. So it is very complicated process. Unfortunately, it is a condition which may or may not be reversible.
Right.
And some people do lose their life because of the graft versus host disease.
Yeah, that brings up to me. I mean, let's see. What do we transplant in the United States or in the world? Right. We transplant bone marrow. Right. That's the stem cells primarily. Right.
Right. Exactly.
Okay. We transplant kidneys.
Yes.
And pancreases.
Yes.
And then for people who have diabetes, we transplant lungs
Yes.
and hearts.
Yes.
And
Intestines.
small bowel, not large bowel.
Small bowel.
Mostly small bowel, yes.
Okay. And livers, we mentioned livers.
Liver is obviously major.
And now there are also the face transplants and then limb transplants.
Face and limb. What do you know about face and limb?
Very little.
I don't know enough to speak about it.
Yeah, me neither, really. It's in its experimental phase. And I know at UCLA they're doing limb transplants now, and I do believe they may have done one face transplant that I know of. And I do think those patients are doing well, but I don't know the specifics.
Well, the trick is you don't want to transplant a dead limb.
No.
I mean, a limb that may be alive but doesn't work.
Exactly.
You've got to do the nerve connection.
Yes. Yeah.
You don't have to do that when you're doing kidneys and pancreas.
No, you don't.
What do you know about that nerve connection? I mean, how successful are we? I mean, we do those when we have a laceration, cuts the nerve, you reconnect the nerve. It seems to work, right?
It does. And I know that so far from what I've been told, the outcomes that, in the first few cases that have been done have been successful, but I don't know to what degree they've been successful. And, is successful mean entire use of the hand or limited use? And if so, how limited? And so
it just amazes me how we, for the longest time, we were trying to transplant organs, early 1900s, and of course the body just about spit it out. It said, no. And we were able to do this. It's that ability to prevent rejection that has been so important.
With medication, exactly. I think the cyclosporin was the first one which, when it came, it's revisualized all the transplants, and then now we have Prograf and Cellcept. These are the two major players now.
And we've got just a minute left before the next step, but they don't quite kill the immune system so bad that the body doesn't have a defense, yet it prevents the rejection. And how does it do that? Very quickly.
It just suppresses our immune system. So technically we are trying to fool our body, and we have to keep we have to adjust that level. Okay, so it's some kind of art, because you don't want to oversuppress them, and they will develop more issues with infection, but you don't want to keep them undersuppressed, because then they will reject. So you have to play one very fine line. Exactly.
Right.
Exactly. Balance. And the more the year passes by, the body keeps adjusting to it, and the lowest immunosuppressive rejection medication you have to keep. If we pick a book from the transplant, which is 5 years old, they will say you have to run like 12 or 13 of Prograf. But if you pick a book which is just recently published, they will say keep it between 8 to 10. So with the time, people are getting used to yes, we don't need to keep it higher. Okay. Keep them lower, less side effects, and keep him on the right. Yes, it's becoming an art kind of thing.
It's an art.
Yeah, exactly.
Yeah, all this is kind of artistic anyway, isn't it? To find out what receiving a transplant is like, On Call visited with Janet Sokolowski, who received a kidney from her brother in 2004.
Well, I've had diabetes now for 25 years, and I didn't take as good care of myself as I should have, and I developed end-stage kidney disease. I was on dialysis for about 1.5 years, and then they matched my brother Kevin up for kidney. So basically my diabetes was my downfall. They did the transplant in 2004. They drew blood on me, they drew 17 vials of blood on Kevin, and they have markers that they have to match up. They call them markers, genetic markers, and there's like 16 or 17, and we matched all of them. Kevin was in and out. He did really good. They did a little laparoscopic to get his kidney out, and then they did a little bit larger incision on me. But he was up and walking like an hour or two afterwards. He came to see me. I'm laying in bed going, well, I'm going to go see Kevin, and there he is. So he did great. His wife was a little concerned that he would have detrimental effects afterwards, but he did great. He was out running in about 3 weeks. And then he did so well that she decided to become a kidney donor. So there was a man in her church that needed a kidney really bad, and Deb donated her kidney to him. So there's 2 donors in their family. And then they leave the other 2 kidneys in, so I have 3 kidneys altogether. I have to take medicine, anti-rejection medicine in the morning and in the evening. I'll have to do that the rest of my life. But, you know, if I can keep my brother's kidney, I will do it. Their life isn't changed. I mean, Kevin went out running, like I said, 3 weeks afterwards. He was just fine. And Deb, his wife, she did fine too. They had no problems at all. They go in once a year and get a physical from the transplant hospital, and they check the creatinine to make sure everything's okay, but it's been perfect. So being a donor is like a little stay in the hospital, and the stay in the hospital is only like 3 days. And then you go home and you recover, and Kevin was recovered in 3 weeks. He was the donor, and Deb was the same way. She was recovered in 3 weeks. It's much better. Now that I've got my kidney, I can do whatever I want to, whenever I want to. No holds barred. It's great.
Thank you, Janet. She is truly a lovely lady, and kind and willing, and you know, not something that everybody loves to do is to be interviewed like this, and she was willing to do this. She had kidney disease due to diabetes, and so ended up with a kidney transplant. How often is diabetes the cause of trouble with kidneys?
Diabetes is one of the leading causes of renal failure. And so I would say the majority of our patients as a result are diabetic.
Yeah, it's one reason why we want to get a hold of that problem. Do you anticipate, both of you, that we're going to have more and more trouble with this kind of a illness, this kidney failure, as obesity progresses?
Absolutely.
Yep, like obesity now has become like 30% in United States. So 30 out of 100 people are obese, and as soon as you cross the age 40, suddenly your hyperpressure becomes issue. Next thing is that you become diabetic and you're on metformin or any other anti-diabetics, and the next step is that your cholesterol goes high, then your liver numbers start going up because you got fatty liver disease, heart issues, sleep apnea. So it's like cluster started as soon as they cross age 40. And we see plenty of the patients in our office now with liver abnormalities, and we have been diagnosing them that the major issue is their obesity. And once they control the weight, things improve.
The problem is that people really don't have the ability to control weight. I mean, it's one of those things that once people gain, they really don't seem to be able to take it off. Or if they do, it's only temporary. The New England Journal studies say that 100% regain their weight in 5 years.
That's true. I mean, and what I experienced in the last couple of years since I've been in South Dakota, when we give them enough time to the patient, okay, because when our new patient come, we give them specifically 1 hour, and we really spend 1 hour with them, counseling them to see, because most of them, they already know what's wrong with them, because they already know that they are obese and so, but they do not know what obesity can cause them in the long term. And when you give them really insight, and sometimes we end up doing liver biopsies, and when they know how soon they can develop cirrhosis and eventually die, their whole lifestyle changes, and we have seen a tremendous amount of improvement in their weight reduction.
People need to realize the danger of obesity. It's huge.
It's huge, exactly.
You know, the killer, the real killer is cirrhosis. I mean, fatty liver disease brings cirrhosis, which brings liver cancer.
Correct. And actually, a lot of places now, they are looking into to start metabolic clinic in which they want to add 4 or 5 different subspecialties and make one clinic in which one person comes with these metabolic issues, I mean obesity, hypertension, hypercholesterolemia. Instead of sending different places, they come in one place and they take care of them. And we are looking into that too. Hopefully we're going to start that kind of clinic in Avera too.
You know, it's like clinics that are, job is to help people with obesity. It kills the doctors. It's an exercise in huge frustration. My sense is that we've got to find something more than just you got to eat less and exercise more. And so there are pills now coming out. There's a new series of pills, and there's surgery for obesity. What do you think in the future for this? I mean, this is part of this transplant issue. I mean, we just looked at, I mean, Janet talked about overweight and diabetes, and then the destruction that happened there. What about the new methods of losing weight?
I think the ideal system would be one where you have, like we try to take a multidisciplinary approach both to transplant as well as patients who have liver cancer. I think you will have to take a multidisciplinary approach to weight loss, which would include a surgeon for those that fail, perhaps an endocrinologist or a general internist, but also a psychiatric team to take care of the psychiatric component to weight gain and dependency upon food and so forth.
All I can tell you is it's very frustrating for the physicians and the dietitians, but mostly for the patients. Please call in your questions about anything involving transplants. 1-888-376-6225. Or you could email them to questions@oncalltelevision.com. Let's take some questions. From Platt, what diseases cause kidney illness? Okay, this one was diabetes, and we've talked about diabetes. What else?
Hypertension.
Hypertension causes kidney disease. Inherited things, polycystic kidney.
Polycystic, exactly.
IgA nephropathy is one. Lupus can cause renal failure.
So IgA nephropathy, which is what?
Oh.
Immune system. His immune system.
It's like an autoimmune attack against the nephrons within the kidney.
As is lupus. Same story. Your immune system says, my kidneys are foreign. They're a foreign body. Why ever it thinks that. It does it though, doesn't it? So immune system disease. So there's a lot of reasons for it, but diabetes is the biggest.
I would say diabetes is the biggest.
Here's from Cody, Nebraska. Nurses and teachers, a nurse who teaches nursing, her students are wondering why can't pancreases be transplanted?
No, pancreases can be transplanted. Maybe the question is perhaps why are they not transplanted as frequently as kidneys? I would say the number of pancreas transplants are far less than the number of kidney transplants in the United States for a number of reasons. One, the selection criteria for both the donor is very specific as well as the recipient. We've gained...
And you can't do a living donor pancreas transplant. I mean, it's got to be a cadaver.
There have been attempts at that, but no.
No.
And I would say that, you know, for the recipients, we require that they be type 1, in our program, we require that they be type 1 diabetics. And we look for those patients who have difficulty managing their diabetes with an insulin pump or exogenous or, you know, subcutaneous injections. And also those who've experienced hypoglycemic unawareness. That's very frightening, where
sugars go too
your
low,
sugars
but they
go
don't
low,
know and they pass out.
No idea, you pass out behind the wheel of a car.
It's a tough area.
Yes.
Yep. Diabetes.
Yep.
That's what we...
Diabetes is hardly the, I would say as a general internist who's taken care of all the problems of adults, you know, my whole life, diabetes is the most difficult, challenging, hard area to take care for. Here's from Sioux Falls, a sister with liver disease, organ donor last time, long time. Can I donate part of my liver to my sister? So that's the question. Can you donate part of a liver?
The partial liver transplant is, we call it live donation. Okay, yes,
of a liver.
Correct. It has been there for last now more than 15 years, and it's more perfected. And actually, in Asian countries, majority of the transplants are done live donation, like in Japan and India and China and etc. Mostly the partial liver is done in pediatric populations, in the kids, because they can live with the left lobe even. So our liver has a right and left lobe, so you can do half liver and you can donate it. But they have to look at how, I mean, body match is also needed, because you cannot put a small piece of liver in a person who is like BMI of 40, I mean with weight of 300 pounds.
And have
so,
them.
Exactly. So your petite body, yes, can adjust that. But most of the partial livers are done in pediatrics, but yes, in adults they do that too.
Periodics in?
Pediatrics, I mean the children.
Pediatrics.
Pediatrics.
Got it, sorry. Here's a question from Miller. Does obesity play a role in the need for transplants?
Absolutely.
Absolutely. We've hit that
yes.
one.
100%.
It causes NASH, which is a fatty injury to the liver leading to cirrhosis. And
so NASH standing for?
Non-alcoholic steatohepatitis.
So non-alcoholic.
Correct. So
steatoalcoholic.
So the name came because one is called ASH, alcoholic steatohepatitis. So if, let's say, we do a biopsy and give it to the pathologist, he can never tell us whether it's alcohol causes damage to the liver or it's a fat. So if you tell him with the history, this person is obese, then he will say, well, it's a non-alcoholic. But if you tell him this person is petite but is a drinker, he will call it alcoholic steatohepatitis. But both can cause the same, exactly same.
And if you're a heavy guy and drinking, then you're double trouble.
Double trouble, exactly.
And that's true. I mean, it is. Cirrhosis is hepatitis is an inflammatory process, and then after the inflammation has gone away, the liver comes back to a smaller size. It's been scarred down. The second time it's scarred down more. The third time it's scarred down more. And that cirrhosis, the thing that scares me is that cirrhosis is at risk for cancer.
Absolutely. And I have one of my patients, he's age of 39, and he is cirrhotic, and from what? From fatty liver. He doesn't drink, but he is age of 39, which is a very young age, and he develops cirrhosis from the fatty liver.
The problems that arise from cirrhosis are myriad. Here is one about niece had a bone marrow transplant, lives in Michigan. How familiar are you with bone marrow transplants? Or even for bone, oh, here's a bone transplant, not a marrow transplant, a bone transplant for a foot and ankle. What do you know about bone transplants?
Well, I know at the time of procurement, when we take the organs that we're going to be transplanting, the teams come, once the solid organs are taken, such as the heart, the lungs, the liver, kidney, or the pancreas, and in some cases small bowel, after those organs have been taken, then the tissue team comes, and at that point corneas are taken, skin is taken, and then long bones for the purpose of procedures such as what may have occurred here.
Do these people who have bone transplants need to have anti-rejection medicines?
I believe they do not. I think they're able to treat the bone in such a way that they remove all the human antigen from the bone, so that, or the recognition that the bone is a human bone, so that it's now anergic, or there's no need, it's not recognized as a foreign entity.
The protein is killed in it.
Correct, yes. That's
and so the protein part is gone, and what's left is the calcium
yes.
matrix, and they use that for the transplant.
Yes.
So, so it's a different kind of a transplant. It's different. The skin transplant, that's a temporary deal to cover skin until they grow their own skin. Do you know anything about that?
I've never been involved in a skin transplant, no.
You know, and I think one of the other things that we really ought to talk about is cadaver donations. I mean, that's a
yes.
whole field. And so
yes.
we are going to address that after this.
Okay.
The decision to be tested and typed to see if you are a good match to be a donor for a bone marrow transplant, is just the first step. The donation will include time, discomfort, and emotional elements as well.
I was a stem cell donor in 2009. About 10 years ago, we were visiting family in Kansas City, and there was a huge drive to get people signed up for bone marrow. And my brother and his wife encouraged my husband and I to sign up with them. And 8 years later, I received the call. It was from the National Marrow Donor Program telling me that I was a potential match for a 20-year-old female with acute leukemia. And would I be interested in donating? I received the phone call in July, and the donation was done on September 14th. So, and throughout that whole time, I'm communicating with the National Marrow Donor Program. I'm doing a lot of extensive testing with my blood work. I think I had 31 vials of blood taken throughout the whole procedure. The best part about the donation is that I'm working very closely with the Heart of America personnel. Rebecca in Kansas City became a dear friend of mine, and I hadn't even met her except through the phone. And they walked me step by step through the process. The Heart of America's purpose is to work with the donor. That's their concern. They take care of me. There's other doctors taking care of the recipient, but I'm their only focus. So I felt really, it was a good sense of well-being, knowing that they were taking care of me. And of course, they cover all expenses. It's just my time is really all I'm giving, time and white cells. I really didn't experience any physical side effects. Emotionally, it was a challenge, and they had warned me that I might have some emotional problems. It's such a powerful 2 days of giving, and even though the physical didn't really affect me any, I was an emotional wreck for about a week.
That was great to hear about her experiences and how she was able to donate. Yesterday we did a radio spot about bone marrow donation, and my wife Joni is trying to encourage people to do this testing so that we'll have enough people for donations of the bone marrow. And we had a dear friend who had had a bone marrow transplant that had allowed her to be alive in the studio with us. And she says, well, thank you so much for coming and being on the radio show with us. And she says, it's nice to be here. And I mean that. It's really nice to be here. She's alive because somebody gave that donation. bone marrow transplant donation efforts, I think, are huge, and we could certainly do anything we can to encourage it. I think you can go to BeTheMatch.com and find a way to do this. If you can't, if you're not having anything anywhere else, just go to the internet and look up BeTheMatch.com. Any other comments that you guys would like to say about it?
Regarding bone marrow donation?
Yeah.
Oh, certainly no. It's very simple to become a donor, and then you're put into a national registry, and it's an opportunity. I mean, it's different than giving one of your kidneys, but you have an opportunity to save a life, and so it's a tremendous gift.
Yeah, with very little trauma. I mean, it's easy. They're drawing it out of the arm instead of bone marrow
into your,
methods anymore. So it's huge. It's a huge thing. I wanted to talk a little bit about some controversy here. You know, there is, as I was going on the literature and trying to prepare for this and write the essay that I'll give later, I went to the internet, and of course I hit right into an essay someone was writing about in the Netherlands, people are doing euthanasia. And of course, they're also harvesting organs, I mean, just before they die, that they're committing suicide. I mean, you know, the question is, it's a very sticky ethical issue. And the more I know about it, the more I would say this. The people who have harvested organs from patients of mine that have died in emergency rooms are about as ethical and as careful and as thorough, and if there's one little question, they say, forget it. And unfortunately, too many forget-its occur. Comment about that, Chris.
Sure. When I was 18 and I got my driver's license, you have the opportunity to check, even back then, I had the opportunity to check if I wanted to be an organ donor.
Yeah.
And at that time, I thought, absolutely not. Because I'm sure that I'm sure there's someone out there who's more important than me that will at some point need my organs. And so the doctors in the hospital will probably let me die so that this more important person could take my liver or my kidneys, because, you know, I'm just a little guy.
Yeah.
Couldn't be further from the truth. In every state in the United States, in order to be an organ, you know, in order for your organs to be donated, you have to first be declared brain dead. If you are, if you're someone who wants to be an organ donor and you suffered a trauma, and perhaps your family is now making a decision where they know that you no longer want to live your life in this way, hooked to machines or in a coma, perpetual coma, then we have an opportunity to also make that last wish come true by doing what we call a donation after a cardiac or circulatory death.
Right.
But there is no way that we can take organs from a donor before they've been declared legally dead.
Right. And that's just absolute.
Absolutely.
And you're aware of this conspiracy, controversial stuff that's going on. Why do you think that happens?
Well, I don't know exactly. I mean, I think for me, there's a lot of unknowns when it comes to what goes on in the intensive care units in hospital. And you know, you may have seen a loved one pass away and not fully understood everything that was going on, or perhaps the physicians that were caring for your loved one didn't communicate with you in an effective way, and so it leaves a lot of questions. And then those questions carry over into the area of donation, and so it leaves a lot of uncertainty.
One more reason for a good primary care doctor for every patient.
Exactly.
Yeah. And
brain dead, as you know, mean patient is dead. Okay, the only thing is working is the brain stem, which is causing the heart to keep and respiration to keep going. And majority of them, they are on ventilator. If you turn on the ventilator, they just go within a matter of minutes. Right. And there's no documented evidence so far that the brain dead person can come back. Okay, well, God has those capabilities to do, but in scientific world right now, we have not seen any evidence that a person who is brain dead come back. And majority of the time, this is what we call a legal death too. And right. That's the time you do the harvesting. There are some other patients whose brain dead is one, and second thing is their heart also stops. So in certain scenarios, you have to harvest those organs too. And kidneys, yes, and liver are on because of shortage of the organs in some transplant centers. You have to do in a patient who may not, you may not want. I mean, that's not an ideal donor when person's heart is also stopped. But there are some other patients who, if they don't get liver right away, they're going to die. So they have to. You have to take that exactly. But they have very small window of opportunity within a matter of Chris can tell exactly time, but it's a matter of minutes before you harvest. Otherwise, that organ will be lost.
Yeah, you lose it. And there's just, I mean, more than 50% of the people who need organs out there die without the organs.
That's very true.
Definitely.
But we cannot go after organs because of that need. We need to use them in the appropriate time. We have to be ethical, and we have to respect the rights and the proper scenario for every person before and after their death. And we need to do it in an ethical manner, and that happens. That happens, and it has happened every time that I've been involved. My whole experience, just can't say it clearly enough. Well, here's another controversial issue. Okay. We've got some questions, but I should probably do that. But I want to talk about cost. Okay. Because one of the huge costs that's going on right now is excessive cost of health care. And one of the costs that we have is this huge transplant cost. Let's take the story of kidney. Okay. Dialysis versus transplant. Can you give me some idea about cost there?
Yes. It depends on which study you read and which numbers you look at, but generally speaking, if you look at the average cost of kidney transplant, for caring for a kidney transplant patient versus a patient who is on dialysis for a year, you're looking at a reduction of at least 1/5 the cost that it would take to maintain a patient on dialysis to pay for their immunosuppression medications following a kidney transplant. And so if you look at that amount of time, I mean, if that individual is able to maintain their organ for 8 to 10 to 15 years, that's a tremendous amount of savings. Then to think that they would be on dialysis for 5 to 10 years.
And then die.
And then pass away, yes.
That's right. And the other thing, I've heard that it's more expensive up front, but the break-even time is about 2 or 3 years. Correct. And then you're way better off with the transplant.
Yes. And the hope is that the patient will return to a job and become and go back to being a productive member of society and able to work and do the things they love to do that they had to give up when they went on dialysis.
Right. And we've looked at those questions. Agricultural exposure, 23 years ago, had kidney transplant due to an agricultural exposure. Have you heard anything like that? Can we respond to that?
Perhaps a chemical exposure?
Yes.
Like a pesticide?
Yeah, pesticide or one of the chemicals, or I don't know. I
don't know. I mean, we know contrast-induced nephropathy for sure. We know, but that is totally different when we do CT scan and so. But chemical
doing too many CTs or too many injections, or
so
used to be the IVP that was the big contrast problem, but we don't hardly do that anymore.
Industrial exposure is a big problem, and I know that we've come across patients with liver failure who worked in an injection mold plant that were plastics and exposed to certain chemicals, and so it would not surprise me.
That's right. And I just don't know enough. It depends upon the thing. I mean, plus there are a lot of illnesses that are related to agricultural. It's a dangerous business. Yes. I mean, people fall and they hurt themselves. I mean, they get caught in augers and lose their hand and go on. Why body doesn't reject a blood transfusion? So explain to me why we don't reject. What are we doing now that prevents a rejection of a blood transfusion? Mostly getting the right match. I mean, that's a matching story.
It's a matching story, but I mean, for the kidneys and the liver, and we do MASH too. Okay. Kidneys are more allogenic, mean they produce more antigens, which lead to further rejection. But with blood transfusion, I don't unless you don't do the cross match. Okay, even if you do cross match, there are certain patients who do develop reaction in the form of mild reaction like fevers, and sometimes they start destroying their RBCs, and so. But we do see, it's not something we don't see, but
we do see some.
Yeah, and I would say the proteins that are presented by the blood cells are less complex than those presented by a solid organ, and that would be the easiest way I could think of to explain it.
Well, but it was the realizing that when some blood transfusions didn't work, we started looking at the blood of the person and the blood of the transfusion blood. You could find that there was the AB and the ABO and the O and all those different kinds of matches. And then we've gone to the next level where there's more other levels of tissue matching. And we've learned that those were the first steps that we realized how to help with kidney transplants. You got to match the organs so that a person with now does that work with transplanting? Does a person who is a O blood person be able to take more kidneys? I mean, do you know what I'm talking about? An O.
They can donate more.
They can donate more.
Yes.
So
and AB
can.
So the universal donor for blood and the universal recipient are the same for organs as well. But for kidney, we also do tissue typing.
That is a lot more, but it's in the same ballpark.
It's in the same ballpark.
And I do know now that when you do a transfusion, you mix the blood of the person who's getting the transfusion with the blood that's being transfused, and you check to see if it's going to take, even though you don't know what, you know all the other matches. Really quickly, how important is it to mark donor on your driver's license? You said no.
Very important.
Say yes.
Very important, yes. That's the number one way we're going to be able to know that you want to be a donor. Should you pass away at an unfortunate time, that's the only way we'll know that you want to be a donor.
Very good.
At this point in time.
All right, we'll be back after this. The dream of transplanting a functioning organ from one person into someone with a failed organ has been around for many years. It was 1902 in Vienna, Austria, where animal kidney transplant experiments began, but they found organs failed after a few days. 7 years later in France, slices of rabbit kidney were transplanted into a child suffering with kidney failure in a desperate attempt to save her life, but the child died about 2 weeks later. Every transplant rescue attempt always failed because of some unknown biochemical barrier. The cause of rejection came in the 1940s when a London scientist defined the body's protective immune system. There to reject invading infections and infestations, the immune system would simply not allow for an organ with a foreign genetic code to be transplanted from another body. The first example where transplant actually resulted in helping the recipient occurred in 1950 when a kidney was transplanted from a dead donor into a 44-year-old woman with polycystic kidney disease. Although the patient's body rejected the donated kidney as expected, the working transplant gave her remaining kidney time to recover, and she lived another 5 years. The second successful transplant, the famous one, was in 1954 when the immune system problem was sidestepped as an identical twin gave up his kidney so the other twin with kidney failure could live. And he lived many years later. Thus the new dilemma. Most of us do not have an identical twin to come to the rescue if kidneys would fail. In order to transplant non-twin organs, the rejection problem needed solving. Finally, in the 1960s, as we learned more about better matching for blood transfusions, we moved to tissue typing to match donors for kidney transplants. At about the same time, we also learned more about turning down the body's immune system using medications originally used as chemotherapy for cancer, and then on and on. Now we can transplant hearts, livers, pancreases, lungs, intestines, bone marrows, as well as kidneys, with improving success and with less rejection. This has been the result of hard work using layer upon layer of scientific knowledge to solve the riddle of the body's important immune system. Transplant is no longer a dream. And with that, we have a few more minutes to talk. We have a couple calls. One was, what can be done for low white cells, red blood cells, platelets, or hemoglobin? So there's the question. Low white cells, low red cells, and hemoglobin and platelets.
Well, the medical we would call them pancytopenia because all the series are low. Now
Yes.
the question is why this person has. We see some diseases like lymphoma or blood cancer can cause pancytopenia, but at the same time, people with cirrhosis, actually it could be one sign that this person has a cirrhosis. And we see a lot of patients who've been referred first to hematology, our colleagues with the hem-oncology, and when they do bone marrow, they find there's nothing wrong. Then the next thing comes, are we dealing with liver disease? And we see pancytopenia, one of the reasons is liver cirrhosis.
A lot of reasons for pancytopenia. Really quickly, if my organs are removed after my death, will my body be treated with respect? Chris, quickly.
Always. Always. There's one thing that's really nice that the organ procurement organization does here in South Dakota, North Dakota, and Minnesota, and that is we take a moment of silence. We'll read something written by a family member, and then we'll start our case. And so we always treat the body with respect.
This brings to a close our show on transplants. I sincerely thank our guest, Dr. Christopher Auvenshine with Avera Medical Group, Transplant and Liver Surgery, Dr. Mumtaz Niazi with Avera Medical Group, Liver Disease, both in Sioux Falls, for helping answer all of the wonderful questions about transplants. And you can help too. Saturday, December 8th, here in Brookings at the Larson Ice Arena, the BeTheMatch Registry will be helping people fill out the forms and do the simple, painless test to become a bone marrow donor. This could save someone's life in a simple, not invasive procedure for the donor. Go there, be part of it. Saturday, December 8th. This is Christmas time. A lot of people might be interested in a book that Judith Peterson and I put together a few years ago, The Picture of Health, A View from the Prairie. Go to On Call Television and look up how you can donate to On Call and get a free book, signed. Next week, we'll have a special On Call addressing the current and anticipated shortage of hometown doctors. Our panel of medical experts will take your call in and email questions. Please be sure to join us for this very important program about hometown doctors. But before we leave you tonight, I want to remind all of you to get the flu shot if you haven't already. There's been 152 confirmed cases of influenza in South Dakota already. 42 of the cases were children under the age of 4, and 26 cases in people over 64. 28 people have been hospitalized, and there's been 1 death. It's not too early to get your flu shot. It's effective for 12 months. There are 2 new components in the flu vaccine this year, so it's different than the vaccine received the last 3 years. The early uptick in flu infections that are predominantly the H3N2 strain shows some worrisome parallels to the nation's last bad regular flu season in 03 and 04, according to the officials from the U.S. Center for Disease Control and Prevention. Just go get your shot. And a takeaway about organ donation from the first surgeon to successfully transplant a human heart, Dr. Christian Barnard: it is infinitely better to transplant a heart than to bury it to be devoured by the worms. Until next time, stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.